Hello and welcome everyone to our August webinar. We have a treat for you today. We'll be reviewing secondary VTE prevention dosing. Do we reduce or not? We're going to focus on RENOVE and APICAP. Next slide. I will be your moderator today. My name is Naomi Yates. I'm a manager for anticoagulation and medication adherence services for Kaiser Permanente. We have my co-host today, Arthur Allen, who's a clinical pharmacy specialist for an anticoagulation program manager at the VA in Salt Lake City. And then we'll be joined today by Stephan Moll, professor of medicine at the University of North Carolina School of Medicine. And we have a treat for you as well. We'll be joined with Jean Connors will join us. She's the medical director for hemostatic antithrombotic stewardship and anticoagulation management services for the hematology division at Brigham and Women's Hospital and Dana-Farber Cancer Institute, and a professor of medicine at Harvard Medical School. Jean, we're going to have to look into shortening that title for you. Okay. Arthur Allen did want to share with you that he is a part of the board of directors with AC Forum and a consultant for Bristol Myers Squibb. Stephan Moll does not have any disclosures to share with us. We want to go ahead and present for you guys some announcements for you to be aware of. First of all, we are having an end of season summer sale. So now is the time. You have until the end of the month to save on different packages that are available. If you're interested in 2024 boot camp package, that is available. That gives you on-demand access to the boot camp and our CARE International Learning Series. We're also offering our conference package. If you'd like the 2025 National Conference, Complete Learning Experience, and the CARE International Learning Series, that is available too. If you would like all three for the low price of $399, that gives you access to the National Conference, on-demand boot camp, and the CARE Learning Series. You can access these through acforum.org or by scanning the QR code at the bottom of the slide. Okay, and we have plans underway already for our 2025 boot camp. This will offer insights from our top industry experts. We have several different dynamic and informative talks. 30 days of enduring content will be available after the conference through November 18th. And we have our interactive chalk talks for deep dives and hands-on learning. Registration is at the low price of $349. Group discounts are available. That again is available at this QR code or at acforum.org. And with that, I am going to hand it off to Arthur to give us a little bit of a history lesson for us of how do we get to this point now where we are considering stepping down our DOAC dosing once the patient has completed the initial therapy for VTE.
All right, thank you, Naomi. I appreciate the introduction. So, this talk is really going to focus on what happens when we're considering secondary VTE prophylaxis. So we're not going to spend a lot of time on VTE treatment, but just to orient us here, this is a great figure that is in Blood Advances from the ASH 2020 VTE guidelines that talks about kind of the timeline of VTE treatment. And we have that initial management, which can range from 5 to 21 days, depending on really the agent that you're choosing. That's what drives that decision. But during that phase, we have what I like to call clot flopping in the breeze, and where patients are at the highest risk of embolization or extension. And so we have an aggressive management approach there. We then have what we consider the primary treatment course for the blood clot that occurred, which lasts from 3 to 6 months. And then notably, this is kind of where we kind of pick up here. There's a decision point for stopping anticoagulation therapy or continuing for secondary VTE prophylaxis that should really happen at the end of that acute treatment phase. And the decision to go on is really no longer about the clot they had per se, maybe why they had it, but not so much about the clot itself. It's really about the risk of future clots based on the presumed or, our concerns about the risk of recurrence of having another clot based on risk factors and so on. So, you know, as you all know, I'm probably preaching to the choir here, but for strongly provoked events, just kind of broad strokes here. Strongly provoked events favor finite duration of therapy where the therapy is stopped. Unprovoked and significant ongoing risk factors favors extended VTE prophylaxis in the absence of significant bleeding risk factors. Now, where does all of this step down versus no step down dosing come from? So when apixaban rolled out their VT prophylaxis really right out of the gate, they planned a study to evaluate, can we get away with essentially prophylactic dosing out beyond that acute treatment phase? And they planned the Amplify extension trial. You see the date there is 2013, so this is not new. Now, it's important to note that the study was done in patients in whom there was clinical equipoise regarding the continuation or cessation of anticoagulation therapy. That is language directly from the paper. Rivaroxaban did not plan directly out of the gate a similar trial, but they, in kind of response in 2017, they published the Einstein Choice trial, really a similar design. In the apixaban trial, they studied therapeutic dose 5 milligrams BID versus 2.5 milligrams BID, the prophylactic dose versus placebo. In the Einstein trial, they studied rivaroxaban 20 milligrams a day versus their prophylactic dose of 10 milligrams once a day versus aspirin. And again, in that trial, they looked at patients in whom there were the patients who were in clinical equipoise regarding the need for continued anticoagulation, or so they thought. Well, I'll get to that in a moment. The Amplify extension trial here, just a high level results. What we know from that trial is that the thrombotic events were similar between the two active groups there on the bottom, 2.5 and 5. But VTE events occurred at a rate fivefold higher in the placebo group. Now, there really was no difference in major bleeding across all three groups, which number one was kind of the first time we saw an active anticoagulant and placebo have no difference in major bleeding. It's kind of an interesting finding there. What we did see is that in the lower dose group, there was less clinically relevant non-major bleeding. So apixaban at 5 milligrams is associated with the highest degree of what they termed clinically relevant non-major bleeding. Similarly, in the Einstein Choice trial, the thrombotic events were similar between the two treatment groups, 20 milligrams once daily and 10 milligrams once daily. There was a threefold higher risk in the aspirin group. Remember, aspirin isn't not nothing. Aspirin does actually carry some efficacy in VTE prophylaxis, so the overall rates were different than what we saw in the Amplify extension trial. But still, comparatively speaking, aspirin group had the highest rates of thrombotic recurrence. Again, across the three groups, there was no difference in major bleeding. And again, what we did see is the clinically relevant non-major and minor bleeding was highest in the highest dose therapeutic rivaroxaban group. Now, let's go back to that question we talked about, who was in the trial. I mentioned that there was this, patients intended to go into the trial that were randomized were those that quote unquote equipoise for the need for ongoing therapy. But it's important if you look at the demographics tables in both of these trials to see who actually showed up in the trials. And interestingly, in the Amplify extension trial, less than 10% of patients actually had provoked VTE, while greater than 90% had unprovoked. And we know good and well that for a long time, the recommendation has been extended VT prophylaxis and unprovoked events. There were also about 12% of the patients that had had prior events, so this event representing a recurrence. And despite trying to exclude cancer patients, there are about 2% of patients with cancer. In the Einstein Choice trial, they had significantly more provoked events, about 60%, but they still had 40% of patients who had quote unquote unprovoked events. And about 18%, even higher risk or a higher number of patients had prior events. This, again, the treatment, the event being treated for this course representing a recurrence. And then about 2.5% of patients had cancer. So I ask you, clinical equipoise, question mark? In my estimation, they studied a higher risk group possibly than intended and found yet the results that I showed you that even though they clearly by review of these data, a lot of patients, there should have been no question of clinical equipoise. Patients, the recurrence rates were quite low, even with a low dose. Now, how did this translate into the prescribing information? Both in the US, both Eliquis and Xarelto include the lower dose in their prescribing information. And in fact, not only do they include it, they say this is what you do. You'll notice the absence of the term clinical equipoise. You'll actually notice the absence of really an option for extended VTE prophylaxis with standard dosing. Instead, it says you do this, and then after at least 6 months, or in the case, I think both of them 6 months, then you do this. And so in the US label, it very much basically says that for extended VT prophylaxis, low dose is what you do. Now, first of all, let me just, again, preaching to the choir, I hope this is very clear to this, this audience, that when we're referring to reduced dose, not all reduced dose is the same. So using apixaban 2.5 milligrams twice a day as an example. If you have a patient who has atrial fibrillation, and based on their patient-specific factors such as renal function, age, and weight, they would, have a dose reduction. That is still a therapeutic intent of therapy. The dose reduction is to avoid supratherapeutic levels and hopefully have therapeutic levels. As opposed to on the right here, when you're using secondary VTE prophylaxis for the purpose of VTE prevention, the dose that reduced dose is for a prophylactic intent. It's not for a therapeutic intent. It's targeting lower levels. So let's keep that straight as we carry this conversation forward. Now, how did this translate into guidelines? Interestingly, it took some time actually before guidelines actually gave a nod to this reduced dose option. But if we go to the most recent VTE chest guidelines, we do see that in fact, as the language suggested, in patients offered extended phase anticoagulation, we suggest the use of reduced dose apixaban or rivaroxaban over full dose apixaban or riva. As you know, there's a difference in recommend, suggest. They actually say this is based on weak evidence, very low certainty of evidence, which is interesting to me. And then there's the remark there that says what they mean by reduced dose. Similarly, same year, 2021, ESC acute DVT consensus guidelines has this treatment regimen, which is maybe a little bit hard to read, but the points I'm highlighting here are that they actually give the option of standard or reduced dose. And they use language that says currently reduced dose of apixaban and rivaroxaban have shown their benefits in patients at intermediate risk of recurrence. Not quite sure why they would say at intermediate risk based on the patient demographics, but I suspect that's probably a nod to there are things we don't know, which is kind of the purpose of this webinar. So step-down dosing takeaways. The extension trial studied step-down dosing in a large population of patients at high risk of VTE recurrence, as I mentioned, unprovoked cancer recurrence. The drug PIs and societal guidelines promote step-down dosing. And then this is when I talk about this topic, this is kind of what is key. You'll hear me say this, in the patient studied. So we know that in the patient studied, you don't get much for the step-down dosing. As I highlighted, no difference in thrombotic events, no difference in major bleeding. You get a reduction in minor and clinically relevant non-major bleeding. But then the question becomes, does the patient in front of you look like the majority of the patients in the trial? This is how I think about this topic. We know that there are knowledge gaps. We know that there are populations perhaps that are not highly represented in the trials. And those issues are where the questions have come from, why there have been ongoing trials like will be presented today, and why we're having this webinar. So at the end of the day, when does Arthur worry about step-down dosing? I have historically, I should say, considered kind of two main categories. One being exceptional thrombotic risk, and the other being potential drug underexposure. So when I think about this, I think about, well, there were a small number of cancer patients in the trials. What do I do with that? I know that cancer is extremely prothrombotic. Known or suspected strong thrombophilias. Thrombophilia testing would not have been included as part of the trial protocol. So there were likely patients in the trial with thrombophilias, but we simply don't know what to do with actual strong thrombophilias. Prothrombotic drug therapy. What if patients are on drug therapy that increases the risk of thrombosis? I think about certain cancer regimens. Anatomic contributions to thrombotic risk. So if you think about things like May-Turner syndrome, like thoracic outlet syndrome, those kind of situations, maybe some vascular, venous revascularization issues where there's perhaps stentings or those kind of things where we simply don't know. Anything that could ultimately result in sluggish flow is kind of what I'm thinking about there. History of true therapeutic failure, and I've spoken ad nauseum about what that means, but if it's a true therapeutic failure, why would you risk that? And then if your spidey senses are otherwise tingling, that can't necessarily put a number on that, but if your spidey senses are otherwise tingling. Now, potential drug underexposure, what does that look like? Well, what are the things that might lead to lower drug levels? Things like morbid obesity, and Stephan Moll on this presentation is, was on the ISTH guidelines, the first and the second. that talked about this, but that guideline was really focused on can we use DOACs for acute VTE treatment, and it didn't focus a lot on what do we do in the setting of secondary prevention and getting away with prophylactic dosing, history of bariatric surgery or other issues that might affect GI absorption, induction drug-drug interactions, as we know, especially as pharmacists. There are a number of head scratcher, drug-drug interactions that aren't absolute contraindications, but that make us kind of go, and if those are induction drug interactions that might reduce drug exposure, you might think about it. And then known issues with adherence. Just if I know that the patient is, half the time they're missing their second dose and they're not wanting to take a once-a-day dose, and if they miss a dose, then they're going to be at lower levels if they're on a prophylactic dose and therapeutic dose. So these are the things that I think about. And have found in discussing this topic that AC providers really fall into one of two camps. They either are from the I will step down the DOAC dose unless convinced I shouldn't, and that's kind of where I fall. There are others who, will say I will not step down the dose unless you prove to me kind of that I should. And I think what we're about to find out is whether or not that is where my favorite wood-turning hematologist of German descent is going to lead us. So at this point, I will hand this over to my friend and colleague, and we will go from there. I think, if I can stop sharing, pardon me.
Arthur, thank you very much. Tell me, are you able to see my slide?
Yes, sir.
Terrific. Arthur, before I go anywhere, can you explain to us what is spidey sense, otherwise tingling? That's the term I'm not familiar with.
As in Spider-Man, when you have the sensation that something's not right, but I can't put my finger on it. You know what it is inherently. I just had to explain it to you.
Fair enough. I didn't see Spider-Man.
Okay.
But otherwise, I liked your summary slide.
Thank you.
I appreciate you giving me an opportunity to talk about this, the dose reduction issue. When do I do it, and what does the RENOVE trial show? First of all, and this is not really part of the topic, but I added this slide. I'm on the consult service at the moment. And one of the things I think is more important, maybe even than the decision, how do we treat at 6 months? Do we dose reduce or not? The question, does this patient really have a DVT or PE when they get treated? We've seen a number of subsegmental PEs that are just flow disturbances, motion artifacts, mixing artifacts. And the question comes up, should this patient be on anticoagulation and what drug to use? But the really question is, did the patient really have a DVT or PE?
Stephan, I apologize for interrupting. I'm actually not seeing your slides. I thought I was. Is that just me or? Oh, wait, maybe we are.
Tell me, do you see it now?
There we go. That is, yes, thank you.
Terrific.
Thank you.
So the first question, does this patient really have a DVT or PE? Or in retrospect, when we see them at 6 months and we wonder, should we dose reduce, did they truly have a DVT or PE, or was it maybe a wrong call? And then secondly, that we are really clear, does this patient, should they really be on long-term anticoagulation, or based on the risk factors, should they really just have been or should be on short-term anticoagulation? I think that's a really key question. And Arthur, I'm focusing, as you appropriately highlighted, on this secondary prevention phase after the initial 6 months. And the question, should we dose reduce? But before I go to the RENOVE trial, I do want to make this point with a different kind of concept, how I think about long-term anticoagulation. And once a patient stops anticoagulation at 3 months or 6 months or whenever, if they have a low risk for recurrence, I put them here in the tip of the triangle, green zone, narrow area. Those are people who have a low risk for recurrence. They had a clot associated with a major transit risk factor, and they get treated with 3 months. Sometimes we go for 6 months, but short term, and then we stop. And then we have the people with a high risk for recurrence. That's the red zone right here. Those are people with an unprovoked VTE. They have a high risk for recurrence, and they should, based on the guidance documents, be treated with long-term anticoagulation. And then we have the people in between with this intermediate risk for recurrence, where we don't quite know what to do. That's the people where we have equipoise. Should we stop or should we continue? Those are difficult. Those are people where maybe the D-dimer can be helpful, or maybe a thrombophilia workup can be helpful, but we still struggle with those people. So what I do when I see a patient where the question comes up, how long should we treat? Based on their VTE risk factors, I put them in the position in the triangle where they are. And then I have an idea, okay, this one should be short-term, here these long-term, and here intermediate risk, don't quite know what's going on, how to best treat. I have two topics that I was asked to present. Number one is the non-cancer patients, and then secondly, we'll get to that, the cancer patients. And there are really 4 relevant clinical trials that are to be considered, or I should say 3 clinical trials and 1 sub-analysis. And Arthur, you have presented the Amplify Extension, the Einstein Choice trial. They've been around for a long time. And then the RENOVE trial that was published earlier this year, and I'll get to that in more detail. And then what I will also present, even though these are only abstract data, unpublished, and we always take those data with a grain of salt because data are not finalized and have not been peer-reviewed. And that's a sub-analysis of the RENOVE trial in obese patients. And I think this is a really important sub-analysis to at least mention. So I was asked to present a case, and this is my simple case. Question, can we lower the DOAC in this patient after 6 months? It's a 58-year-old man. He had an unprovoked proximal leg DVT in 5/2024. He's been on apixaban, 5 mg Q12, so full therapeutic dose since then. His weight is 95 kilos, body mass index is 28.7, so relatively normal weight, overweight but not obese, and CBC and creatinine are normal. Where do I put this patient in the recurrence triangle? Well, unprovoked DVT, high risk for recurrence if they come off blood thinners. Down here in the red zone, broad base, consequence, long-term anticoagulation. And it's really this patient where we now wonder, should we lower to the prophylactic secondary prevention dosing, or should we use the full dose? Now, my practice in this patient until earlier this year, before RENOVE was published, and that practice was simply based on the Einstein Choice and the Amplify Extension trials that Arthur presented, I would have treated this patient with full dose anticoagulation. And why? Because both of those studies were set out to enroll patients where the provider had equipoise. They didn't quite know what to do. And those are, as I showed you, the people with intermediate risk for recurrence, where we don't really know. It's not high enough, it's not low enough. What do we do? It is those patients that until the beginning of this year, and still now, I would treat with prophylactic dose. And I particularly would choose the prophylactic dose in the elderly, low body weight, and high risk bleeding. And in these people with clear unprovoked VTE, normal risk for bleeding, I would have used full dose until earlier this year. Now, here I have listed the new RENOVE trial that we're discussing versus the Amplify Extension trial. And as Arthur pointed out, these were both set up to have patients enrolled at this intermediate risk for recurrence, equipoise. Now, in the RENOVE trial, this was truly a trial that was set up to enroll patients who had a clear indication for long-term anticoagulation. So those would be people in the red zone. So these were the ideas why these trials were, how the trials were designed and who was meant to be enrolled. So Amplify Extension and Choice, here this intermediate risk. But as Arthur showed, really the people enrolled into these trials were not the ones with equipoise, or at least where in 2025 we don't have equipoise. The majority of people in the Amplify Extension were here in the red zone people. And in the Einstein Choice, at least 40% had unprovoked VTE, so not intermediate. But this is the reason why until early this year, some people would say unprovoked VTE, I would treat with a long-term anticoagulation because the trial was really set up to enroll patients where we didn't know what to do, where we had equipoise. And other people already said earlier this year, well, I'm going to dose reduce them because the majority of them were people with unprovoked VTE. It really depended on how you looked at these two trials. RENOVE is really the red zone patients that were enrolled into the trial. And turning to the RENOVE trial, it was a large trial. You see in the at 6 months, 1,383 patients were either on the prophylactic dose randomized or on the full dose. And it was a really good long follow-up, 37 months, which is really nice. Roughly half of the patients were treated with apixaban, and roughly half of them were treated with rivaroxaban. And what I particularly like about this trial, it was not funded by a pharmaceutical company, but by the French Ministry of Health. It's a French study, independent funding. What did it show? To no surprise, similar to what the Amplify Extension Einstein Choice trial showed, looking at symptomatic recurrent VTE. That was with a low dose, 2.2%, with a full dose, 1.8% of patients over the next 3 years. And there was no difference between these two groups, statistically no difference. So the low dose was as effective as full dose. That's reassuring, not that new compared to the Amplify Extension and Einstein Choice trial. And then regarding major and clinically relevant bleeding, and that is full dose, the bleeding risk was 15.2%, and the low dose, 9.9%. And if you compare the two, it's listed right here, that was statistically significantly different. So an advantage for the low dose, less significant major and clinically relevant non-major bleeding at the same time with the same efficacy. And what these authors did, and I like this as a graph, they looked at the net clinical benefit, or, and it's a little oddly phrased, for me it's really, what is really the bad outcome? The bad outcomes would be a recurrent clot or major bleeding or clinically relevant non-major bleeding. So bad outcomes together, if you add the two bad outcomes, you had more bad outcomes with a full dose versus the low dose. So really the low dose looking at bad outcomes is better. And that's statistically significantly different. That's shown right here. So this study shows that really the low dose at 6 months seems to be advantageous and attractive to do because you get less bleeding. So if I put this into question, is lowering of the dose beneficial for both apixaban and rivaroxaban? Because this data that I just showed you, which is the primary outcome data, looked at the whole group of people treated with a DOAC. So people might think, well, what about apixaban and rivaroxaban if you look at them separately? And the answer is yes, the benefit is there no matter whether you treat with apixaban or rivaroxaban. And those are supplemental data. And I'm pointing them out because so often, well, at least as far as I'm concerned, so often it's too cumbersome to look at all the supplemental data and we go for the primary publication. But I think this is interesting. So this is splitting up the data, the 1,300 and something patients, into who was treated with apixaban and who with rivaroxaban. And they looked at the low dose after 6 months and the full dose. And then they split it up here with apixaban. If you look at recurrent clot, the full dose right here is a little bit to the right, so it's better, but statistically not significantly different. So either one is good to use. And with rivaroxaban, you find the same. It's a little bit towards better with a full dose, but clearly statistically not significantly different. So with both of these drugs, no matter whether you use the prophylactic dose or the full dose at 6 months, the recurrence rate is the same. If you look at major bleeding or non-major clinically relevant bleeding, so the really significant bleeding, what you see is, yes, with both of these drugs, there's less bleeding. It's to the left of the vertical line right here. But what you see is it's statistically significantly beneficial, the lower dose. So less bleeding with the lower dose with apixaban, as well as less bleeding, even more impressive with rivaroxaban. So equal efficacy and benefit with either one of the two drugs. And if you look at net benefit, so that's again, I'm looking at the composite of bad outcomes, either recurrent clot or the significant bleeding issues. If you look at the rivaroxaban, clearly statistically significant, there's benefit. If you lower rivaroxaban from 20 down to 10, you get clear benefit and you have less bad outcomes. With apixaban, it's still to the left of the vertical line, but it's statistically not significantly different. So a little less impressive, but still pretty convincing that the answer is, yeah, lowering the dose seems to be beneficial for apixaban as well. However, statistically not significantly different. So my conclusion from this main RENOVE trial publication is, with rivaroxaban, lowering the dose at 6 months is beneficial and it makes clinical sense. With apixaban, maybe I'm a little less impressed, but not really much less impressed. The lowering dose doesn't look quite that beneficial, but it's still very reasonable to consider. What are the strengths of the RENOVE trial? Well, there was a long median duration of 3 years, which is pretty impressive. There's a low rate of loss to follow-up of the patients in the study. There's good adherence to the medication. And as I mentioned, it was non-pharmaceutical company funded. Limitations that have been pointed out by an editorial by Saskia Middeldorp, it was an open label design. However, the adjudicators were masked to treatment. They didn't know which drug the patient was on or what dose they were on. And then Saskia points out there's a lack of power for relevant subgroup analyses. And I think that's important because what I just showed you a minute ago is rivaroxaban and apixaban, do they both have benefit? That is already a subgroup analysis. The study is big enough that it's worthwhile to look at, and I think it looks pretty convincing that with both of them, you have less bleeding, or at least a significant trend towards less bleeding. However, it really gets into limitations of the subgroups. So what did this study do to my practice? This study was published in March, and the question, can we lower it 6 months in patients with DVT PE? Well, I continued and still continue to use a prophylactic dose in people where I don't quite know what to do. And we've decided, based on D-dimer, patient preference, maybe some thrombophilia workup, to use a prophylactic dose into intermediate patients. Now, after the RENOVE was published, I was much more willing to put the people with an unprovoked VTE, and I'm referring to proximal DVT or PE, on prophylactic dose, as a number of people had already done, but many people had not. But the RENOVE trial gave me confidence, yeah, this is reasonable to do to decrease the bleeding risk, and it's as effective as the full dose. But a question I had, and I always wonder about the severely obese patients, not so much the body mass index of 31 or 34, but rather the 35 or 40 and above, because those patients are typically limited in the studies. The question is, can we dose reduce even in the very heavy patients? And then it was nice to see that in June of this year, just 6 weeks ago or so, at the International Society on Thrombosis Hemostasis meeting, the RENOVE trial had a sub-analysis of obese versus non-obese patients, and I'll show you those data. But I do want to say these are abstract data, so as I mentioned, non-peer-reviewed, and thus not really suitable for clinical decision-making, but it helps us a little maybe look forward and be a little more careful with what we do. So I want to present a case number 2 to highlight the struggle that maybe we have now. The same 58-year-old man that I had with an unprovoked proximal leg DVT last year on apixaban since then at full dose. Now he weighs more than what I had before, weight 135 kilos, the body mass index is 40.8, so severely obese. CBC and creatinine again normal. So again, I use my recurrence triangle. Yes, he's still here, unprovoked clot in the red zone. He should be on long-term blood thinners. So the question to us now is, do we feel comfortable lowering this patient to the prophylactic dose at 6 months, or do we continue full dose? And my answer at this point will be, I would continue the full dose. And I'll show you why. This sub-analysis with all its limitation that I mentioned, looked at patients in the RENOVE trial with a body mass index less than 30 versus the patients with a BMI above 30. And they looked at recurrent VTE. And if you look at the normal weight people, is the low dose better than the full dose? No, it's equally effective, but a little bit here towards the low dose is better. But really, it's whether you use full dose or low dose, the recurrence rate is the same. If you look at the obese patients, and it's a whole group, severely obese and mildly obese, the whole thing is shifted towards the right, that there's a trend. It looks like the full dose is better, and it's almost statistically significantly different. Wow, that gives me pause to think, should I really be putting the obese patients on the low dose? Maybe those are the people where full dose is appropriate. If you look at the bleeding risk, in the normal weight people, well, the low dose is better, and that's in keeping with the overall results of the RENOVE trial. Low dose has less bleeding, and it's statistically significantly different. But if you look at the obese patients, yeah, there's a trend towards less bleeding, but you lose the statistical significance of that. So maybe the bleeding is not beneficial, so you may have a higher risk of recurrence. Maybe you lose the benefit of bleeding. So then again, if you look at the net benefit, which is really a nice way, I think, to look at the combination of recurrent clots plus bad outcomes with bleeding. Well, if you look at the normal weight people, yeah, the overall benefit is clearly there. Less bleeding, same recurrence rates, this is significant. It's appropriate to lower those people. But if you have the obese patients, clearly there's no net clinical benefit anymore. Because you lose some of the efficacy and you have some higher risk for bleeding, so the overall net clinical benefit gets lost. So in those people, you could argue you could either lose the low dose or you use the full dose, but don't expect to get any net clinical benefit. You may have a higher risk of recurrence. Now, then the authors go a little further, and I think that is really too far. Because the groups, these sub-analysis groups get really small. But what they wanted to show is, well, as the body mass index goes up, as the body mass index goes up, what does the overall outcome look like? And here we have a BMI less than 24, then here BMI 25, less than 25, BMI 25 to 35, then here the more obese, and then you have recurrent clots, major bleeding, and then again the net clinical benefit. And what they show with these graphs, and it's, I think, this is a slide from the presentation at the ISTH meeting. It's a little misguiding, but it looks like the benefit really gets less with a higher body weights. So there's a risk of recurrence, huge confidence intervals, as you see, because the numbers are so small. Here with major bleeding, clearly benefit with a low body weight and with a normal body weight. And maybe there is less benefit in the severely obese or more severe obese patients, but huge confidence interval. And then the net clinical benefit, the arrow here, the black one, suggests that the more heavy you are, the less is the net clinical benefit. But if you really look at these individual data points, yeah, clear net clinical benefit with a low dose in the normal weight people or in the less than 25. Yeah, probably some benefit here in the BMI 25 to 35, and then probably a loss of benefit in the more severe people. This is the effort to really understand more the severe body mass index behavior, but the data are limited due to numbers. But what the authors conclude is in patients with BMI above 30, reduced dose versus full dose was potentially inferior, and I'm a little concerned about inferiority as well in the obese and maybe the more obese people, potentially inferior on the risk of recurrent VTE, and it was not superior on the risk of bleeding issues, so you lose the benefit. And then they said, and this is taken reference to the last subgroup analysis that I showed you with those arrows going down, a dose effect response was suggested with more recurrent VTE in patients with a heavier BMI, and they say additional analyses are needed. So after the ISTH data, and right now, what is my clinical approach? Can we lower DOAC doses after 6 months? And this is my practice. There's always some individual decision making, but in general, in the intermediate risk for recurrence, prophylactic dose seems very appropriate based on all 3 studies, Einstein Choice, Amplify Extension, RENOVE. And then in the unprovoked VTE, it seems reasonable to dose reduce in the normal weight people and to use a prophylactic dose. But and this is what the going towards red means, as the body mass index gets higher and the patient is obese or more obese, I am not quite comfortable to lower the prophylactic dose based on this abstract data sub-analysis, and I tend to use unprovoked VTE, particularly with the patient has already shown for the last 6 months I've tolerated the full dose well, and if they're heavy and at normal risk for bleeding, it may just be better not to dose reduce and wait for additional data in the future to come out in the more obese patients. And if you were to ask me, well, at what body mass index do you then decide to do full dose versus prophylactic dose? My answer would be it's not like one number where suddenly I say, oh, now I'm going to keep full dose, or below a certain number, I'm going to lower the dose. The more obese, the more concerned I am in general and would not lower the dose. So the summary of these 2 cases, before we go to cancer, a 58-year-old man at the unprovoked proximal leg DVT presentation on a DOAC for the last more than a year. If the weight is normal or obese, in this red zone patient, unprovoked clot, I use prophylactic dose, but in the patient with a BMI above 40, I would use full dose and reevaluate once per year. That was the non-cancer patient RENOVE trial. And then a little less extensive is the cancer patient population. And this is taking reference to the APICAT trial that was also published this year. And there's a second trial that I'll briefly mention, which is the EVE trial that was published last year. But before I go to these patients, again, something that's self-understood for the majority of us, but still so important, it's the question, does this patient with cancer who had a DVT-PE or PE, do they really need long-term anticoagulation or not? And it's the charge to all of us to identify all the risk factors, not just focusing on its cancer-associated VTE, but cancer-associated VTE has all different types of flavors. The patient may have been immobile due to surgery, due to immobility in the hospital, and then develop a clot. That may be very different to the patient who has cancer and is completely mobile. IV catheters, the congestive heart failure. This is not a cancer. This doesn't quite show up correctly. But the point is, in cancer, there may be the chemotherapy, the radiation therapy, the cancer surgery that predisposed. It's a multifactorial nature of the clot. And that then makes us draw the patient, or makes me draw the patient into the recurrence triangle. Cancer is not the only risk factor for the blood clot because clots are multifactorial. So the 3 studies, I mentioned the APICAT published this year, the EVE trial last year, and there had been an earlier study, which really was a single-arm study that looked at 6 months, the lower dose of apixaban. That was not really helpful. There is some bleeding, there's some recurrent clot. It didn't really tell us what we should be doing. The EVE trial was really set out to look at safety and not so much efficacy. It was a much smaller study. It really showed, though, that both doses had the same risk for bleeding, and it had the same risk of recurrence, given the low numbers, somewhat limited conclusions, but it didn't really make a difference in cancer patients whether used at 6 months the full dose versus the low dose, which makes a little bit of sense. Cancer patients bleed easily, and they may just bleed because of cancer, and if you have an anticoagulant on board, you bleed more. And here it was the same with both. The APICAT then was a much larger study, and therefore New England Journal publication comparing those 2 drug doses at 6 months. And the demographics, these are cancer patients age 67 in both arms right here, roughly half male and half female. The body mass index, important to keep in mind since we are having some concern about the more heavy people, 27 was the median body mass index. And then there was a variety of different cancers, and I'm not listing them here. It's breast, colon, and what have you. And one can do a sub-analysis or can look at that depending on what cancers one deals with. But I have not found that helpful for the individual or for the conclusions of this study. But I wanted to show to you that a number of people, 2/3, had metastatic cancer, so quite prothrombotic. Published right here, I had mentioned the pretty large size, and this is the risk of recurrent VTE. Reduced dose, 2.1% had a recurrent VTE. With full dose, 2.8%. So actually, with a full dose, numerically more, but really statistically meant the low dose is non-inferior. It's as effective as the full dose. So you can use either one if you try to prevent recurrent VTE, if that's your main goal. Question is clinical bleeding. And there's benefit of the low dose, which is very similar to the RENOVE trial, that the low dose is as effective as full dose, but it's safer. So if you look at the clinically relevant bleeding here, with a reduced dose, 12.1% of patients over the 12 months, and with full dose, 15.6%, and here you see statistically significantly different. So clearly a benefit, and you don't lose any efficacy. Following the publication, there were a few letters to the editor with very appropriate comments, and this is not new to any one of us, particularly the pharmacists who think about this all the time, but I do too in the cancer patients. They caution in cancer patients who always think about drug-drug interactions that may increase either the plasma levels or decrease the plasma levels of the direct oral anticoagulant, or vice versa, that it decreases the efficacy or increase the efficacy of the chemotherapeutic drug. So always check on that one. And then they said, well, the complex and vulnerable patients, we really need to pay attention. They may well have a higher risk for bleeding. The ones who are malnutrition, have cachexia, absorption and clearance of the drug may be changed. People with renal and hepatic impairment, they may have a higher risk for bleeding, so really pay attention to that. And people with advanced coexisting other diseases, so very individualized decision-making may factor into the, not just the, oh, we're going to use the low dose, keep in mind, particularly renal and hepatic impairment. So my overall conclusion before I will turn to Jean, Dr. Connors, and Arthur with questions, what do you think? This is what I do in August 2025. In non-cancer patients, I've already summarized this, the prophylactic dose in the intermediate risk for recurrence, unprovoked, with relatively normal body weight, and the heavier the body weight, the more I favor the full dose anticoagulation at 6 months. And then in cancer patients, the dose reduction at 6 months seems reasonable because you gain that it's safer from a bleeding point of view. But one also has to pay attention to other issues, particularly drug-drug interactions and additional bleeding risk factors, a fungating colonic mass or a bronchial mass that has already bled, where clearly I would prefer the low dose over the full dose. Whereas if it's a more solid patient by weight who's doing well, who's tolerated the full dose anticoagulation well, has metastatic disease, I might choose in that patient to continue the full dose, but revisit every so often. With that, I thank you for your attention, and we can open it, Arthur and Jean, to comments from you guys.
Thank you so much, Stephan. And if you wouldn't mind pulling down your slides, we'll go to full screen here. Excellent presentation as always. You know, and what I'm seeing here really is this kind of continued theme that we saw from the prior trials that you don't necessarily get much for it, because even though we looked at this through the lens of kind of net benefit, most of that's driven by the difference in clinically relevant non-major bleeding. Just because you don't get much for it doesn't mean we shouldn't consider it in, the majority of patients. We're kind of closing the gap. I said that there were these kind of populations that maybe didn't look like the patients in the trial. We're narrowing what those are. And for me, what this kind of filled in was I kind of highlighted there are two groups. One is kind of the significant thrombotic risk group where I'm just scratching my head, and the other is the kind of drug underexposure. And what we see from the subgroup analysis, what this has kind of done for me is said, well, gosh, maybe those aren't the same. Maybe thrombotic risk isn't as important, in fact, as kind of this other group where we're worried about drug exposure with the piece that's highlighting from obesity. And again, I would point out, in case it was missed, generally when we're talking about the concerns about use of DOACs in the obese, we're talking about the morbidly obese greater than the ISTH guidance, specifically that cut point was greater than a BMI of 40. Whereas in the subgroup analysis, a little concerningly, the cut point was actually 30, which is at the beginning of the BMI kind of obese categories. So I would highlight that. I do want to jump to Gene. Gene, for your overall thoughts. First of all, the most important question is, do you know what Spidey senses are, and do you use them in clinical practice? And then the second would be just to get your thoughts on kind of the overall, what is your takeaway from all of this?
Okay, well, first of all, thanks for having me here, and Stephan and Arthur, fantastic presentations as always. Spidey sense. I was actually part of the group that reviewed the EVE trial data and a little funding there from BMS, Pfizer. But I had a discussion with cancer VTE people in practice at that time. And I was already using dose reduction strategies for things like multiple myeloma patients who had like a caffeine DVT and were on an immunomodulatory like Revlimid or pomalidomide type drug. So to get back to you, so the Spidey sense is there. I know what it is. I don't know how to define it, but I think we do recognize that there are some people that are very concerning, and that you cannot calculate their risk. And they kind of might be in the gray zone of Stephan's triangle, but those are the people that we think about more than once. And I think these data help us sort the patients in a better way in Stephan's trial with regard to recurrence risk and efficacy, because we're really looking at efficacy and safety. I mean, I think, Arthur, you did a great job pointing out, and Stephan, the differences between Amplify Extension and Einstein Choice. And I do think the fact that there were fewer unprovoked patients with unprovoked VTE in the Einstein Choice changes the recurrence risk, right? And so when we see similar efficacy, well, what does that mean if their risk is lower? So again, wonderful efforts on both your parts at pointing out, and we really need to be aware of who's enrolled in the trial. I like to say the best of the best of the best get into the trials, but what about the patients sitting in front of me? So I think very good job at that. And again, I think that comes through to the RENOVE trial, and that's why it was such an important study. And even though it didn't quite meet the non-inferiority endpoint for the efficacy, the numbers were similar numerically, and the decrease in major bleeding and particularly clinically non-relevant major bleeding. And so for all of us who take care of patients on anticoagulants, we know that constant nosebleed that's been lasting intermittently for 5 days, or the hematuria that causes the cancer patient to stop their apixaban matters. And so I think that these are very important trials that will move the needle forward. I do want to bring up one other parallel trial, and then we can open for questions. There was a somewhat different analysis called the Combine AF analysis that took the major atrial fibrillation trial, DOAC versus warfarin trials, and they looked and sliced and diced the populations to look at all the efficacy and safety endpoints based on body mass index and weight. And they did find an interesting parallel in that those that had a BMI greater than 40 actually had higher stroke rates on the DOAC compared to warfarin, and also interestingly had higher bleeding rates. So I think we need to carefully consider in our populations with VTE and cancer you know, the BMI, because I think it does matter. But to your point, Arthur, where do we draw the cut point, right? So that AF trial had close to 60,000 participants, you know, randomized into warfarin, right? We're talking about therapeutic dose versus prophylactic dose DOAC. I think there's still a lot we need to learn.
Yeah, excellent points. All excellent points. And you know, just to say, you know, clinically relevant non-major bleeding, we tend to kind of bat away a little bit. But you know, the patient that had a 2 a.m. visit to the ER and ended up with a rhino rocket, it wasn't minor to him. In fact, I had a patient years ago that taught me this lesson when I was like, yeah, the Yagi nosebleed, those things stink, until he showed me a picture of him with a rhino rocket and blood running out of his eyes from his nasolacrimal ducts. I thought, okay, that, call it what you want, but that's a significant event to that patient. So Naomi, I wish I could riff on this like for the next hour. We have very limited time. Do we have kind of questions that we can kind of group together and maybe try to hit these rapid fire?
Yeah, we do have several questions. They tend to kind of hit similar themes. So the first one was related to cancer. Should we be considering cancer type when deciding whether it's okay to reduce the DOAC?
My answer would be probably yes. If I may answer that, the mucosal cancers, GI cancers, gastric, they have a higher risk for bleeding with a DOACs in general. And there I would have a lower threshold to go. There I would like to see the patient on the lower dose. And then similarly, patients who've already shown that they bleed more easily for whatever reason, and that's typically the fungating mucosal luminal cancers.
I just want to add
Urothelial
one
would
point
probably
to
be in
that.
that group as well, I would say, right, Stephan? Like urothelial cancer is another group.
Yes.
The one caveat to that is that I do think the populations enrolled in this trial matter a bit, because the intent was to give a year of anticoagulation, right? So when we look at how they break out the populations, they were prostate cancer, they were breast cancer, and even colon. And metastatic disease in those patients may be different than other types of tumors. They have, you know, hormonal treatment. People live many, many years. And so they're bleeding risk profile as well as their recurrence risk. You know, as Stephan pointed out, 66% were metastatic, but metastatic breast and prostate have very different risk profiles than the GI and the GU.
Thank you. Next question. So there have been questions asking about testing the roles of DOAC assays or D-dimer in decision-making regarding the dose.
I would not use a D-dimer. I use a D-dimer in those intermediate risk patients that I showed you in the middle of the triangle to determine should they be on blood thinners or not. But I don't use it, and I'm not aware of any data that help us decide should they be on the full dose or the low dose. And then what are the testing? Drug levels?
Yeah, drug level.
No, I mean, no, I would not use that.
Yeah, as I pointed out, we're really targeting prophylactic doses anyway. So I don't know that we really know what to do with drug levels for therapeutic intent. maybe Jean, maybe you have a brighter idea of what to do with prophylactic intent and drug levels.
Yeah, no, I will tell you that we do have a little bit of a different practice here. We were early adopters, even before FDA clearance for apixaban and rivaroxaban levels. And we have had some, we don't know what to do with these, but we have patients on the lower dose, but they have renal insufficiency and other issues, and their levels are much higher than those reported in the phase 3 trials where they did measure levels. What to do about it is not clear, but if they have bleeding, we are concerned and sometimes actually switch to a non-DOAC choice. So I think for therapeutic dose, the decision is easy if you draw levels and they're super high, and you have a rationale to dose reduce, which, you know, for AFib we know doesn't work, but clearly it works in preventing VTE. But we need so much more data in that area.
Thank you all. We're at the top of the hour. Thank you so much for our guests today. Thank you for everyone who was able to join. We appreciate it. I'm glad we did the announcements at the top because we always run out of time. Sorry we weren't able to get to everybody's questions, but thank you so much for joining. We'll see you next month.
Thank you.